Pandey sir, I cannot actually overlap it.
Acha, okay. Uh,
Yeah.
Dr. Ajay sir, can you stop sharing for a moment for the intro slides? Then maybe you can share the screen once again. Yeah. Thank you so much, sir. Yeah, Akshay.
Yes, sir, we are good to go.
Okay, great. So we are live?
Yes, sir.
Yeah, okay. Uh, Hello, everyone. Thanks a lot for joining in today's program of Cardio Colloquium. So today, actually, we are going to discuss on a very interesting trial that is AIR. Like we are not today, we are going to discuss on the 30 years of legacy data and how actually beneficial into the post-MI patient, especially. So today to discuss this, we have a very fantastic team here from the if I talk about moderator. So for today's program, the moderator is Dr. Ajay Kumar Pandey sir. So Ajay Kumar Pandey sir is senior conventional international cardiologist and head of department Galaxy Hospital from the Varanasi with over 3 decades of experience into the cardiology space. He is recognized with the multiple awards like Young Cardiologist Award and the Chikitsa Sri also. And also he has a degree in the American College of Cardiology and from the European Society of Cardiology and he has been multiple associated with multiple bodies and he has been renowned faculty known by the across India. And talking about the today's panelist, we have Dr. Ashok Kumar sir. He is a DM cardiology from the SDN Arogyam Hospital, Patna, and then followed by Dr. Anshul Gupta, DM Cardiology from the Pulse Hospital from the Jhajjar, and Dr. Ashutosh Bhardwaj, DM Cardiology from the Bhardwaj Heart Care from the Chandigarh city, and Dr. Indra Kuldapati sir. He is also DM Cardiology from Downtown Hospital, Guwahati, and he also pass out from the AIMS. So we have a really good panel, the team of doctors here talking about on the air to ARS 30 years of legacy data, sir. So, Dr. Ajay Kumar, sir, over to you to take this session forward.
Okay, thank you, the MQ people, for this wonderful session which has been organized today. And good evening to all of you, all my learned colleagues, those who have joined from different
Good
parts
evening,
of the
sir.
country. Yeah, good evening to those who all have joined from different part of country to have a this evening discussion regarding ACE inhibitors and the perspective in post-MI cardiac patients. I'm really sorry that I could not uh, be stationed and discuss this topic because I was traveling and trying to reach to a stable place, but unfortunately I'm delayed in the on the way. So to start the today's discussion, I'm sharing my slide and we will have a discussion further. So is my slide visible to all of you?
Yes, sir.
Is my slide, yeah, is it visible to all of you?
Yes, sir.
Am I audible in my slide? Is visible to all of you?
Yes,
Right,
sir.
so slides are
Audible
visible,
and
sir.
visible.
Yeah, you are audible and slide is
Okay,
visible too. So
okay,
go ahead.
okay. So the 30 years of A to ARS navigating RAS inhibition in post-MI patient is today's discussion. And in this discussion, I will be having an overview of ARBs, any post-MI patient inhibitors, and what do the current literature suggest regarding present, data. Now coming to ARBs first, in the discussion of post-MI patient, there are key evidences that ARBs are important drugs in post-MI. And there are two important trials, though they were quite old trials when we have cleared our DMs. And during those days, that these trials have come up the Optimal and Valiant trial, and losartan and valsartan were compared with captopril, the very important drug those days. And losartan 50 milligram once daily was compared with captopril in Optimal trial, and there's a non-significant difference in total mortality in favor of captopril that time. So the captopril was really favoring over the losartan. But valsartan is ineffective as captopril in patients who are at high risk for CV events after MI, because the molecule was different, and the combination of valsartan with captopril increases the rate of adverse events without improving survival. This we very well know about it. So none of us were using ACE-ARB together, but valsartan was as effective as captopril. So the data was during those days in these two trials were either equivocal or captopril is better than the ARBs. If you look into this optimal trial in myocardial infarction with the angiotensin 2 antagonist, there's a non-significant difference in total mortality in favor of captopril. And so the ACE inhibitor should remain the first choice treatment in patients after complicated acute MI. And since those days, we were using quite a lot ACE inhibitors in our post-MI patients. Losartan cannot be generally recommended in this population because this optimal trial has not shown that robust benefit over captopril. And then the Valiant trial and the Valiant in acute MI, they've shown that their mortality from any cause and cause-specific mortality was similar in the three treatment groups, and the rate of secondary endpoint of death from cardiovascular cause, recurrent MI, or hospitalization for heart failure was similar in the three groups. So the comparison of valsartan was little comparable to captopril. So that was the real data regarding the ARBs. Now, for the recent days, as Arnie has grown up his evidences in heart failure patients, those who were the first trial, the paradigm HF, which was done comparing the ACE inhibitor like enalapril with Arnie, that is valsartan and sacubitril. Those are the group of patients, those were stable heart failure patients, and they were not having any hospitalization. But later on, a Paradise MI trial was done with angiotensin receptor and neprilysin inhibition following acute MI, and primary result of the Paradigm MI trial was quite interesting. And because this was the trial which was done in acute MI patients from half to 7 days with an LVEF less than 40% and a pulmonary congestion, plus any other risk factor which were noted here, like age more than 70 years, GFR less than 60, diabetes, prior MI, AF, LVEF less than 30, Eclipse class 3 or more, and STEMI without reperfusion. But the major exclusion criteria was prior heart failure, clinical instability, and GFR less than 30. One arm, the sacubitril valsartan was used, and there is other arm where ramipril was used in 5 milligram BID. Nearly a similar amount of patients were there, and sacubitril valsartan group had, going to 97 and 103 milligram BID. There's no run-in period. It's a double-blind active control, and the event-driven 711 primary endpoints were done. Primary endpoints were CV death, heart failure hospitalization, outpatient development of heart failure, and secondary endpoints were CV death and heart failure hospitalization. And this was the data, though the hazard ratio was 0.90 with sacubitril valsartan, and the number of events were lesser compared to ramipril. 7.4 per 100 patients here with ramipril compared to 6.7% with 100 patients here. The educated primary outcome, if you look into the sacubitril valsartan and ramipril group, the patient they do have a primary outcome event rates lesser in the sacubitril valsartan, but the significance was not that statistically very robust. CV death, heart failure hospitalization, and outpatient heart failure, all those have doesn't shown very significant effect. And if you look into the hypotension and cough, definitely hypotension was more valsartan group compared to cough, which was more in ramipril group. But if you see the other side effects like renal impairment, hyperkalemia, and liver abnormalities, they are more or less similar, except that angioedema part, which was a little higher in ramipril group. The summary of this Paradise MI trial was that sacubitril valsartan did not result in a significantly lower rate of CV death, heart failure hospitalization, or outpatient heart failure requiring treatment. The result which we are expecting in Paradigm HF, this was not seen in these acute MI patients when they were treated and compared with the ramipril. And the pre-specified observation of reduction in both the investigator reports of the primary composite as well as in the total educated events supported incremental clinical benefit of sacubitril valsartan. The safety and tolerability of sacubitril valsartan in this AMI population was comparable to that of ACE inhibitor. So we were, quite tuned to using ACE inhibitor for a pretty long time, and I personally remember, and since my 25, 30 years of clinical practice of post-MI patient, we always, put our patients on as early as possible within 24 hours of ACE inhibition and mineralocorticoid receptor antagonists like epinephrine and all, if there's no significant hypotension and no contraindication. So basically, the Paradise MI trial, cannot beat ramipril in patient with acute MI. There are different comments came up after this Paradise MI trial that the Paradise sacubitril valsartan did not outperform the ACE inhibition. It makes the question that benefit of sacubitril valsartan and so on. So what we were expecting with ARNI in post-MI patient, we didn't, receive those. Now looking into the ACE inhibition post-MI trials, we all know for a pretty long time, there were selective high-risk population and long-term. The SAVE trial, AE trial, and TRACE trial, they all have included different population. And the broader ACE inhibition trials were Consensus 2, GC3, and ISIS4. SAVE 1992 survival and ventricular enlargement study, which was an important study with ACE inhibition, randomized double-blind placebo-controlled, where MI with LVEF less than 40% between 3 to 16 days, MUGA baseline and 36 months, and captopril maximum 50 milligram TDS with placebo and follow-up of 24 months. There were quite good results, like captopril group showed 19% reduction in mortality and 25% reduction in recurrent MI. The cavity dilatation was reduced. These benefits occurred equally in patients who received thrombolysis plus beta blocker and in those who did not. So it was independent of thrombolytic drug therapy and beta blocker. So we all understood with the SAVE trial that ACE inhibition is having an independent benefit in spite of beta blocker or thrombolytic therapy. And since those days, we were quite comfortable using ACE inhibitors in our clinical practice, and particularly in post-MI patient. Now looking into the TRACE trial, which was published in 1995, Trendolapril cardiac evaluation study. It was a double-blind placebo control in AMI with wall motion index of less than 1.2, randomized between 3 to 7 days, Trendolapril 1 milligram per kg per day, follow-up for 24 to 50 months. There is a 25% reduction in mortality and 15% reduction in recurrent MI, 20% reduction in sudden cardiac death. There are other evidences for ACE inhibition in post-MI, like ISIS4, GC3, and CCS1. They all have shown, the different drugs were tried, captopril, lisinopril. The captopril was quite a lot used those days as a short-acting ACE inhibitor, and they were found to be effective. Now, the last very important trial was acute infarction ramipril efficacy, ARES study, which was published in 1993, double-blind placebo-controlled trial in acute MI with transient or persistent heart failure and MI between 3 to 10 days. Oral ramipril 5 milligram BID versus placebo and followed for 15 months. There's a relative risk reduction of 27% in ramipril group compared to the placebo group. And After that, then the ARI extension study came up in 1997. It was basically designed as a double-blind placebo-controlled, and around 600 patients were there, and follow-up of 42 months to 59 months. And the beneficial effects of ramipril started early after MI and with heart failure are sustained over 3 to 4 years despite the discontinuation of medication at 1 year. This was a very important finding which has come up in ARI extension study. The relative risk reduction in mortality 36% and absolute risk reduction of 11% means that 911 treatment of 9 patients with ramipril for an average of 1 year will result in 1 additional survivor in 5 years. So ramipril's long-term survival benefit in acute MI patients complicated by heart failure came up with ARI survival trial, which was published recently in 2021. And the aim was to assess the long-term, around 29.6 years after randomization, the magnitude of impact on length of survival observed after treatment with ramipril. That was a target dose of 5 milligram BID when compared with placebo. And what was observed in this survival benefit trial of ARI, that up to the patient was followed up to 30 years, and the life expectancy and all-cause mortality was seen in these patients, and it was very well observed in that median survival time was 8.3 years for placebo versus 9.6 years in a ramipril group. So that clearly shows that extension of life by 14.5 months, and survival crosses at 14 years to the time of randomization. The life expectancy was greatest at about 15 years. Life expectancy was improved with ramipril across all the comorbidities. And this was seen that, the life expectancy difference and the life expectancy ratio and the median lifetime difference for patient randomly allotted to placebo or ramipril group. The diabetes group was having 32% versus 5%. Previous MI, heart failure history, hypertension, angina was all different ratios were shown in this slide. So to summarize the ARI survival trial, what does it show? An impact that substantial survival gains with ramipril treatment for 15 years beyond the blinded treatment condition. And overall, for every day a patient received ramipril, on average, his or her life was extended by a further day. That's a very important, outcome which we have learned from this ARI survival extension study. And there is a relative risk of survival for patients with diabetes was increased for 54%. So the patient of diabetes post-MI, those who are allocated with ramipril 30 years, by now they're followed, showing quite a significant risk of survival benefit. And patient with diabetes, previous MI, previous heart failure, hypertension and angina each benefited on an average from ACE inhibition. Treatment with ramipril for about 1 year when started early post-MI in patient with heart failure result in a survival benefit which is sustained over many years and offers on average an extension of life on an additional 1 year. So the concluding remark of the ACE inhibition, what I can say is that treatment with ramipril for about a year when started early post-MI in patient with heart failure results in a survival benefit which is sustained over many years and offers an average on extension of life of additional 1 year. So that's a great news which has come up with this extension of survival ARI study. Now, if you look into this guideline directed, presentation of post-MI state of art review, we all see that there are different medications in spite of all those interventional therapies which we do many a times for our patients of acute MI. There are important medications. The most important medication, as we all understand, is the dual antiplatelet therapy in patients of acute coronary syndrome, and statin and target lowering of LDL cholesterol. But if you see the other important therapies, as I have already discussed previously in my previous slides, the ACE inhibition has shown benefit over thrombolytic and beta blocker. So there are other very important drugs and needs to be started within 24 hours of index MI events because early initiation of ACE inhibition within 24 hours leads to remodeling and many more benefits of over the myocardium. And a 40% of survival benefit from ACE inhibition is confirmed in the first day. But many times my colleagues, those who are practicing interventional cardiology, didn't take a note of this important drug, which is or many of my physician colleagues, those who are treating acute MI patient day in and day out, they forget to start this ACE inhibition in first 24 hours of the index events, suspecting of hypotension or something like that, which is not always the case in all patients. And then within 24 hours, we should always avoid beta blocker for first 24 hours for ongoing heart failure. And early introduction of aldosterone antagonist like aprenon or aldactone benefit is time dependent, should be started within 7 days of index event. And the reevaluate eligibility for beta blocker, and I always say that there's no hurry of starting beta blocker if you have not used in early acute MI phase. And we all have, more or less practically stopped using IV beta blocker, which we used to use in our residency days or whenever we have passed our DM as a registrar in acute MI patients. And now more or less beta blockers need to be started before discharge in all such patients. And when the patient is not hemodynamically unstable, and after discharge, it is critical to titrate the doses of medications, including ACE inhibition, beta blocker, and optimal levels of even statins and all those things. So post-discharge follow-up is very, very important. So what I mean to highlight from this important slide to all my colleagues as well as the people, those who are participating in today's evening program, that interventional cardiology and cardiology doesn't mean only intervention. They also need to focus on the important medication which need to be started in a real important time frame. Like first 24 hours, we should start ACE inhibition. In another, after 24 hours to discharge, ARBs, mineralocorticoid receptor antagonist and beta blocker before discharge, as we always focus on dual antiplatelet therapy and statin. Early ACE inhibition therapy offers a maximum benefit. That's what I mean to say, and we should always look into it. The JACC acknowledged ARI first chemical study of 1993, post-Mager infarction heart failure, and ACE inhibition should be administered within 24 hours for heart failure patient of EF less than or equal to 45%. Heart failure patient of EF less than 40%. Significant survival benefit, 40% conferred on first day of treatment. Early initiation is important. So as we understand that, heart failure patients, all heart failure patients are not same. Acute MI heart failure patient, we have got robust data for Ramipril, the ARE study, which has shown, and Progress MI trial, which was done by Arnie, because the Arnie has scored over ACE inhibitor in the stable heart failure patient, but still the data is MI. We all very well aware about it, and we many times even practice it's a guide directed. And similarly, 2020 ESC guidelines for the management of acute coronary syndrome in patient presenting without persistent ST segment elevation has given these recommendations that ACE inhibitors or ARBs in case of intolerance, ARBs in case of intolerance to ACE inhibition are recommended in patients with heart failure with reduced ejection fraction, diabetes, or CKD unless contraindicated, like severe renal impairment, hyperkalemia, etc., in order to reduce the all-cause and cardiovascular mortality as a class 1 drug. So we should not shy away to use these drugs. Now, my esteemed panelists are with me, and it's very encouraging and enlightening to me to have such wonderful colleagues of mine from different parts of country. So as this panel discussion is going on, I will like discuss, in post-MI patient, post-revascularization, what is the starting dose he will recommend and how do he will titrate the dose. Now it is over to Ashutosh.
No, thank you, sir. Thank you. First of all, it was a very nice and informative presentation, sir, regarding the role of ACE inhibitors in post-MI patients. Sir, coming to the question, the systolic BP, I usually start at a systolic blood pressure of 90 millimeters of mercury or more. Though it is not a fixed value, more importantly, the patient should be free of the signs and symptoms of cardiogenic shock. That means there should be adequate organ perfusion, means the sensorium is all right and the patient's urine output is fine. And studies also show that symptoms are more important than the actual number of the systolic blood pressure. So usual cutoff would be 90 millimeters of mercury of systolic blood pressure. So I usually
Very true.
start with
I
either
truly agree with you. Yeah. I truly agree with Dr. Ashutosh that we do the similar type of, real world practice or something different than what the guidelines say, that we should not,
Right, sir.
keep on starting 5 milligram BID Ramipil on the very first day. And if you can say that in a real world situation, if my patient's systolic blood pressure is more than 100 or 110, I can start with 205 or 2.5 milligram BID, or otherwise with 90 milligram or so, we can start with 1.25 milligram
Right, sir.
BID. And as Dr. Bhardwaj has rightly pointed out, that his renal functions are fine, urine output is okay, he's not in shock. Many times we see that the patients of acute MI blood pressure is 90, 100, 110, and they've got adequate perfusion and they have got adequate urine output. So we should not shy away and restrict ourselves in starting ACE inhibition in these patients. And what I always suggest my younger colleagues that start with lower the dose, titrate it gradually, and even maybe at the time of discharge, if the other things are there, it is good to have a ACE inhibition in a smaller dose, like Ramipril, maybe 2.5 milligram BID if the blood pressure is ranging around 90, 100 or so. If the blood pressure is good enough, patient is hypertensive, we can go up to 5 milligram BID as well. It is better to start all these three drugs, Ramipril, mineralocorticoid receptor antagonist, and beta blocker, even a smaller dose before discharge, than not to start any one of them if it is no contraindication. So I think Dr. Ashutosh also agree with me.
Right, sir. Sir,
Thank you,
regarding,
Dr. Ashutosh.
thank you, sir.
It was a nice presentation from your side. Now, the question which I want to pose to my other colleague, Dr. Anshul Gupta, that is Dr. Anshul is on board here.
Yes, sir. Good evening, sir.
Good evening, Dr. Anshul. Sorry, I'm unable to display my video because of some connection
Yes,
issues.
yes.
So
Yes,
what
sir.
you
No
will
issues,
be, will you switch the patient to an ACE inhibitor if the patient at the time of MI was receiving the ARB for hypertension, or
sir.
what is your take, or what is your opinion like to do
So
that?
first of all, thanks for giving a beautiful, enlightening lecture regarding ARB. Sir, we used to see we usually the patient who are already on ARBs, we continue the same ARBs after the MI also. According to the blood pressure, if we see if the patient is having BP in 130s or 140s, we usually give the dose of telmisartan 20 or losartan 25, or if he was on 40 milligram of 40 milligram of telmisartan, we usually continue the same only. Do not switch to the ACE. What is your
Right, yeah, you are very much right, and there will be difference of opinion on these issues, and we all in the real world situation, we all face a different type of problems, and even we also have faced that many times many of our patients are on ARBs because for the treatment of hypertension.
yes, sir.
Most of the time ARBs and this for acute MI, what we do in those patients, like we will look at the data what we had of valsartan, because it is comparable to captopril, but losartan good. Most of the time in our clinical practice, the many
Yes,
of us telmisartan, not
yes, sir.
valsartan.
Yes,
So if we have got, if we see the data, scientific data, definitely valsartan is comparable to the ACE
yes,
inhibition,
sir.
but we didn't have head-to-head trial on telmisartan versus ramipril.
Yes,
But there were trials in particularly in acute MI patient, but there were trials comparing on like on target trial, which have shown that there's a non-inferiority of telmisartan over the ACE inhibition.
yes, inhibitor.
So what I will like to do in my own personal practice, that definitely if the patient, somebody is on, many of our patients are on telmisartan. If he's on valsartan, definitely I will like to continue the valsartan and not stop it, because if you start ACE inhibition today, after switching out from ARBs, definitely there will be some time, like the half life of telmisartan to get the tissue levels, you know, uh, get filled up is around 4 or 5 days. If you
Yes, sir.
start telmisartan today and 4 or 5 half lives will be there, then the tissue level static tissue level will be achieved. A patient who's already on telmisartan, I will not like to switch it off and then change it over to ramipril. But
Yes, sir.
definitely, or the patient is on already on valsartan, I will not like to do that. But if he's on losartan and the ARB was started uh, not because the patient had a ACE inhibitor induced cough. Many times our physician colleagues, I do agree that many of our cardiologists, they don't get afraid of ACE inhibitor induced cough, because though it is 10-15% of patients, they do have ACE inhibitor induced cough. But this, if we explain them that this ACE inhibitor induced cough is a good effect of the drug and it may sometimes go away, our patient may tolerate some time. But for some patient, definitely it is very troublesome. But I have
Yes, sir.
often seen with my physician colleagues, they immediately switch off the ACE inhibition and put them on ARB. Even the patient is on ACE inhibition for some 10 years, 15 years. So this is my take that I feel like to switch, not like to switch from ARBs if the patient is on valsartan or telmisartan. But if it is on losartan or other ARBs, maybe if the reason was not starting, the reason ARB was not because of patient had AS inhibitor induced cough, I will like to switch over. This is my personal take. So thank
Very
you,
well, sir.
Dr.
Yes.
Anshul. Now coming to
Thank you,
my
sir.
other colleague, Dr. Ashok from Patna. Uh, I welcome Dr. Ashok in the
good
discussion.
evening, boss.
And
Good
the
evening.
question, good evening, Dr. Ashok. And the question which I would like to discuss with you is that how early do you think an ARNI can be initiated in a patient post MI? What is your own take?
Actually, in our own practice, we often use ARNI even in the first day of whenever the hemodynamically patient stabilizes. Only then we use ARNI, that they don't need inotropic support, they don't need IV diuretics. Only then we start ARNI. And we have gone through the Paradise MI a bit more critically. Actually, the Paradise MI was planned for the superiority, and it doesn't prove their superiority. That's why that doesn't mean that this ARNI is inferior to ACE inhibitor. This is my point. Whenever you will go through the recent meta-analysis, even subgroup post hoc analysis of this Paradise MI trial, you will see. And even in Paradise MI trial, there was numerical benefit in ARNI subgroup rather than Ramipril subgroup. And one more
Very
thing, you will see the dose difference. We all agree that 200 milligram twice daily ARNI is definitely superior in terms of BP reduction to 5 milligram twice daily ramipril. So these molecule has been compared. That's why the hypotensive episodes was more in Paradise MI rather than comparing with the ramipril. So in first day, whenever the patient is hemodynamically stable, we start early even in post-MI patients. Yeah.
Very true. I agree with your comments, and there are some gray areas still, lying in between. And definitely, we all understand that ARNI has a superior mechanism of action compared to ACE inhibition, and that the different trials have proven ARNI better over ACE inhibition. The only part which we still not started in our clinical practice. I agree with your comment and your proposition that ARNI can be equally good, and it has been shown to be as equally important, not inferior, at least particularly to ACE inhibition. So many of my colleagues are using were doing the similar type of practice as you have said, that starting the lower the dose,
Yeah,
we have
definitely.
already seen that the higher doses of ARNI causes hypotension more, and we usually do go up to 200 milligram, usually titrating our of MI. What my personal choice is that the patient left ventricle ejection fraction is more 40%. Still follow the older pattern of what ARE or other trials have, because we are getting ease of comfort of using a molecule for some 20-25 years or so, because we are using ramipril in acute MI patient since very early days of our cardiology career, like since 1997 or 1996 or so. So since those days, we are using these drugs as a, you know, so we are more comfortable titrating ramipril, and we are more happier, uh, and our mindset is saying that we are not afraid of using of hypertension in this molecule. But definitely, I agree with you that RNI is as good as ACE inhibition, starting early with smaller the dose, titrating it up. But what personally I say that the patient LV function is less than 40%. RNI scores over more than the ACE inhibition. So we didn't have such a long data as ARI survival extension with ACE inhibition like ramipril, which we have seen. But definitely over the time, RNA will score. And but using ACE inhibition initial 1 year gives a very important benefit, survival benefit over and above thrombolytic therapy and beta blocker. Maybe long-term trials or many more trials on RNA will also give the similar type of result, maybe better. So thank you very much, Dr. Ashok. And now I'm inviting my other colleague, Dr. Indra Kuladipati. And the question I posed to him for discussion is, what is your opinion, Dr. Indra, regarding the post-revascularization? If you find LV systolic dysfunction of EF less than 40%, but without clinical heart failure in your patient, will you put the patient on ACE inhibition or RNI? Over to you.
Yeah, thank you, sir. So now probably I think for us, if, in case of almost all epidemi, unless they have already on ARB that we discussed previously, I think we start with ACE inhibitor. The ramipril is a commonest drug we use, and we continue to give ramipril yeah, early post discharge and probably. Now the question is, if the patient is already on ARB and especially like they are already getting some like valsartan or losartan, we continue the same drug based on chemotherapy, adjust the dose. Now, this situation, the particular specific question is that you do not have clinical heart failure, and if we start with a ramipril or ARV, I think we continue the same drug. But in my cases, if like this patient do not have clinical heart failure, but normally we look at the other patient, our patients in terms of revascularization is complete or not. If complete, then because sometimes symptoms be very deceptive. And nowadays we commonly go for biomarker. So ProBNP is normally done at hospital, then at a follow-up of around 4 to 6 weeks. And if the patient is on ACE inhibitor and no clinical heart failure, but the ProBNP is substantially elevated, normally I switch from ACE inhibitors to ARNI if there's no contraindications. Like our main concern is hypotension, because many of our enteroamide patients BP is not too high start weight, and we most of the time we start at a very low dose, 1.25 or 2.5, some 5 milligram. So if that is not the case, but if the person is not clinical heart failure, but EF less than 40%, if the biomarker like probability is elevated at 4 to 6 weeks, if there's no contraindication, if I think that person can tolerate ARNI, normally this is the time I switch from this inhibitors to ARNI. Listen.
Thank you, Dr. Indra. I agree with your decision. That's what the real world situation is. We all are very well aware about the benefits of ARNI and ACE inhibitor together. But I truly, appreciate your point of, objectively measuring anti-proBNP level. The only issue is the cost of the patient. But I understand that, the cost of therapies are quite higher compared to, cost of measuring anti-proBNP. And it is always better to, at the time of discharge, like those patients, those who are having LV dysfunction, to have a track over the anti-proBNP level may give us quite a good amount of objective evidence at how the patient's LV function is improving or not. I do agree with you that, starting with ACE inhibition, and the previous colleague, Dr. Ashok, has already, discussed that ARNI is as good as MI, Cardace, MI trap. There's no, the non-inferiority is there. So, but truly, I agree with you that we can start with ACE inhibition or ARNI, and can switch over the patient. Those definitely having EF less than 40%. Personally, I will also like to switch once the patient is stable at discharge and follow up and is tolerating ACE inhibition properly. Switching them from ACE inhibition to ARNI will definitely give him an edge over. But the patient LV function is around the mid-range ejection fraction 40 to 50%, and then I'm not worried about, and I will continue with ACE inhibition alone, and may not like to change this ACE inhibition to ARNI, because still there are a lot of the one more important objective which I found in my clinical practice, that there is a good combination drug of beta blocker and ACE inhibitor, which comes at a single pill combination. And because beta blocker and ACE inhibition are two important drugs in both my patients, and we will like to reduce the pill burden in many of our patients, because OPDN says, sir, can our medications be reduced? And we always try to look into if they have got a combination pill. And I'm really very, happy with having a good ACE inhibitor and a beta blocker combination. So that's very important. So the question in post-MI patient, post-revascularization, when do you like to start a beta blocker? Dr. Andhra Kuladipati, can we answer?
So, like here also, want to start as early as possible. May not be on 0 hour. Once person is hemodynamic is stable, and post time obviously revascularization have been done primary PCR or maybe early PCR after thrombolysis. Once person is this part revascularization part is complete, or person is not fit for revascularization. Sometimes one person not willing. Probably obviously the heart failure is a good heart failure is a contraindication, so acute pulmonary edema and cardiogenic shock. But unless those patients who are not in cardiogenic shock or impending cardiogenic shock, like 2 months of tachycardia on high dose of oxygen therapy, IV diuretic, IV vasolators, except those obvious contraindications, thrombotic therapy. And now I think
Beta
both
blocker
ACE
therapy
inhibitors
needs
and
to
beta
be ruled
blockers
out.
we want to start very early, maybe on
And
within 24 hours. But again, we have to
beta
also
blockers,
customize some
beta
patients.
blockers
They are
still,
on
beta blockers we still are not in a hurry to start. Why? Because
Yeah.
if it is not started within 24 hours, which was an all the trials which were done in acute MI were given IV beta blocker starting in the first 24 hours. That momentum has gone, and IV beta blockers are nowadays preferable and we seeing ACE inhibition or an for 24 which and Dr. Ashutosh is
Hi, sir. Sir, good
this
evening, sir.
meeting.
Sir, regarding the beta blockers, the level of evidence for metoprolol is a slight better
Beta
as compared to the other
blocker
beta
like
blockers.
to use
Sir, for post
metoprolol.
MI, for post MI, post
Yeah, for
revascularization
post
patients, so the level of evidence for metoprolol is slightly better and on the higher side as compared to the other beta blockers. If the and it also depends on the comorbidity. Suppose the patient is having a comorbidity like COPD or bronchospastic disease, then a higher beta 1 selective beta blocker may be beneficial like bisoprolol. But otherwise, I prefer to use metoprolol in post MI patients.
Yeah, I truly agree with you. And metoprolol is a very good drug.
Right, sir.
And I will like to strengthen your confidence in beta blocker by saying that our respiratory physician colleagues are also comfortable using beta blockers in COPD and asthma.
Right, sir.
So metoprolol is equally cardioselective as bisoprolol, and we don't find many of our patients. So bisoprolol, labetalol, these are preferred by many of our colleagues, but they are equally effective and they can be of well tolerable in patients of COPD and asthma. Now coming to my other colleague, Dr. Anshul Gupta, at what dose you initiate and how do you up titrate the beta blocker in a post MI patient, post revascularization? What is your opinion?
Sir, in our clinical practice, on the basis of heart rate, blood pressure, I used to start usually start bisoprolol 1.25 milligram. If the patient is having a tachycardia of more than 90 or more, then I give 2.5. Usually, I start 1.25 bisoprolol or metoprolol 25 milligram. And according to BP, if patient is very well having BP of 130, 120, then I straight away start with 2.5 bisoprolol, sir.
Very true. I agree with your practice that we all are having different practice, real world situation, and I agree with you. Starting with bisoprolol and metoprolol, the both of them are used with. What we prefer, as in our clinical practice, that as Dr. Ashutosh has told, we start with smaller doses of metoprolol, even 12.5 milligram BID,
Yes.
and you can understand that metoprolol can be given even TID doses also. So we
Yes, sir.
many times go to 12.5 milligram TID if we want to up titrate, but start with 12.5 milligram BID and then gradually to up titrate.
Right.
Maybe it depends upon the up titration, or because each individual is having a different. We all understand nowadays is
Response.
a personalized medicine is what is required in each and every patient. What one
Yes, sir.
patient tolerates, others may not tolerate. So we have
Exactly.
seen that we patients are tolerating metoprolol 100 milligram BID, TID, even, but there are very few group of patients those who do that. But it is always better to put them on beta blocker before discharge if there
Yes,
is
sir.
no contraindication in these patients. Thank you, Dr.
Exactly, sir.
Anshul. And
Thank you,
now
sir.
I'm coming to my other colleague, Dr. Ashok. What is your
Hi.
advice on ACE inhibition plus beta blocker combination which I was
I
talking
actually
about?
I'm very fond of
What do you
using this
like?
combination. So left and right, I'm using this combination in my prescription. But particularly in post MI cases, I used to start this combination after first month of visit. Why so? Because in during hospitalization, even post revascularization, my preferred molecule is beta blocker, metoprolol, particularly tartrate salt in 6 hour or 8 hourly interval. And after building first 15 days, I switch to succinate and up titrate the dose of ramipril according to hemodynamic status. And whenever the patient tolerate well metoprolol and ramipril, after then I often combine these molecule in a single pill combination. And after first month, most of my patients remains on this combination rather than separately.
I guess there is a technical issue at first, and we'll just wait for a minute for him to join back.
Okay.
Okay, no issue. Pandey was
Sorry, I lost the connection. It means there was only last question was left. So I truly agree with Dr. Ashok's comment that we all use in our real world situation, not to early 1 week or 15 days or so. Tolerable dose specified, then we can combine these two combination of ramipril to reduce the pill burden. 5 milligram. Many times I use them BID, or many times I use them OD, depending upon their blood pressure and heart rate. And even 50 milligram and 5 milligram can be used BID or OD, whatever the situation is. So now the last question which is there, which I see I can't. Yeah, that is from Dr. Anshul. And
Yes, sir.
will you recommend shifting the patient from ACE inhibitor to ARNI post revascularization? What is your opinion? As we have
Sir,
discussed a lot,
yes,
Paradise, my
Paradise.
trial, and all those things. What is your opinion?
Sir, if we have already started patient on Ramipral 1.25 or 2.5 once a day or twice a day, and he is very well tolerating. So, in the initial period of admission in the CCU, I think we should continue that only, and then in the follow-up, if patient is having ACE-induced cough or other any other rash or other symptom, side effects, then only we should switch on RD. Please.
Uh, I truly agree with your comment, and that's what we all differ in our clinical practice.
Yes, sir.
But what I used to do in my own practice, that which I have already discussed, that, and one of our colleague has already highlighted also, that we look at an objective evidence of anti-pro-BNP. I'm
Yes, sir.
really very comfortable starting ACE inhibition in the early post-MI phase within 24 hours. We use it very frequently without significant hypertension. Sometimes we have burnt our fingers, and the patients had some problems, and they have hypotension and renal insufficiency, and the creatinine and potassium were raised. We have to stop it also. I couldn't say that all the time I was really successful in putting them on
On
all my acute
inhibitors.
MI patients in 24 hours.
Yes.
But definitely I was more happier because using it for a pretty long time. And maybe once the patient is stabilized, looking into their anti-proBNP level, if the anti-proBNP levels are high and they are having real significant heart failure symptoms, I will definitely like to, maybe some a month or so, or 15 days or a month or so, I will like to shift him to uh,
RD.
less than 40%. All those are post-MI patients where EF is less than may have crossed 1 month or so. This is my personal, but it depends upon their.
Totally agree, sir. Agreed, sir.
So I think that was the last question which was there. And is there any other slide was left? I'm unable to look into the slide. Yeah, the last question. Do you consider anti-proBNP as a deciding marker for choosing ARNI over Ramipril? To all my panelists, I think one of the panelists have already, made this point, and I do have a, can raise my hand as higher the anti-proBNP and lower the EF. I will definitely like to use ARNI over Ramipril. What my other panelists are saying. And the other question is, will you start an ACE inhibitor in all the patients with ACS, whether revascularization procedure was performed or not, to get the mortality benefits? For the other take of my other colleagues, please opine. Anyone?
Yes, sir. ACE inhibitors for all ACS patients is actually recommended, I think so. Sir, because they also reduce the afterload and reduce the strain on the heart. They improve the endothelial function also. They have a role in stabilizing the atherosclerotic plaque also. And more importantly, they prevent the ventricular remodeling. So as a rule, I think ACE inhibitors should be given to all ACS patients to achieve these benefits. In long term, they can
Very
also
true.
reduce the mortality.
Very true. We all have seen that, the benefit of ACE inhibition is over and above the thrombolytic therapy and beta blocker. So there's should not shy away of using ACE inhibition in patient with ACS, whether the special procedure was performed or not performed. Many times, many of our patients, those who are not having a, pocket filled with money, or they are not having the insurance, they didn't able to get it primary PCI. They need to be hospitalized, or they put on medical therapy and conservative management. So we can do, add dual antiplatelet, high dose statin, block them. We have with the talk. Thank you very much, and I will like to discontinue sharing my slides. It is.
Thank you to the esteemed panel. It was a wonderful discussion amongst all of you, and I'm sure everybody has gained some of the other clinical pearls from you all. Sir, we also have a few questions in the chat box. I can just take them up one by one, and any of the panelists can answer them. The first one is post MI, does ARB have benefits compared to ACE in ventricular remodeling?
I can't hear what is the question. Post MI?
In post MI, does ARB have benefits compared to ACE inhibitors in ventricular remodeling?
All those benefits which were shown, I've already discussed the ARB trials, and losartan was not better compared to Ramipril. Valsartan was found to be equally effective when compared, and
Right, sir.
definitely the whatever the benefit was ARB compared to ACE inhibition was more or less of the similar which ACE inhibition used to do. So still what we do as an using an ARB in post MI patient, like those who are already taking ARB and came to us in an acute MI phase, if they are on valsartan or telmisartan, I will not like to change it immediately. Or the people, those who are intolerant to ACE inhibition, like having cough, Many times we start ARBs, so people those are intolerant to ACE inhibition. And LV remodeling or all those benefits are like similar, but ACE inhibition is not as equal to ARB because there are many plaque stabilization roles and many other important roles of ACE inhibitions are there. The molecules both look like same RAS inhibition, but we all understand that RAS inhibition are not same. Even if you use the similar molecule, similar class of drug with the different molecules, the drug's effect may be different. So I think that might have answered the question. Any
Right.
other questions?
So one last question. Do you prefer to use ramipril in high CV risk patients for CV benefits and reduce chances of MI in future?
If you ask me personally, yes, I do, because the HOPE trial, particularly if the patient is diabetic, and if the person is having diabetes and a high cardiovascular risk, definitely adding ACE inhibition will give a lot of benefit to plaque stabilization, improving the microangiopathic changes and microalbuminuria, even cardiovascular benefit. So if the patient is diabetic with high cardiovascular risk, particularly, yes, that is my take on. My other colleagues can respond and give their opinion.
Dr. Gupta?
I totally agree with the sir that there is a evidence of ARB, including telmisartan and valsartan, and they are totally comparable with the captopril, ramipril. So we usually continue the same. And again, post MI starting with ARNI can cause hypotension, and a smaller dose gives the same benefits as 200. Yes, because we should start the drug as soon as possible, and patient it is a individualized approach to every patient. If patient is having lower side BP, then we usually start with smaller doses of ARNI. Third question is, how do you see differential mode of action of ACE and ARB? So no more difference between the mode of action, because ultimately they are inhibiting the RAS system by different. The only difference is they are acting on the different level of the RAS system. Thank you, Ji.
Thank you very much, Dr. Anshu.
Thank you, sir.
Thank you so much, everyone. And I just would like to thank all the audience as well for coming in on a busy Sunday. It's Gudi Padwa, New Year for all the Hindus, and Eid Mubarak to everyone else as well. So I think with this amazing panel discussion that we've had here today, thank you so much, our esteemed panelists, and thank you so much, all the audience, for joining in this evening. Thank you so much, sir. Please have
Thank
a
you.
Thank you.
good,
Thank you. Good night. Take care, everybody.
Good
good
night.
night. Take
Good
care.
night, sir.
Thank you, sir.
Right, sir.